Hello, everybody, and a warm welcome to this webinar entitled Novel Anemia Therapies. This is a webinar jointly sponsored by the International Society of Nephrology and KDIGO. My name is David Wheeler, and I'm a nephrologist from London in the United Kingdom. And I'm delighted to be joined today by Volker Haase from the US and Lucia Del Vecchio from Italy. The webinar is going to be 1 hour in length. We have two 20-minute talks from Volker and Lucia, and then we have 20 minutes for questions at the end. And you can offer your questions up online so that we can answer them at the end of the webinar. So without further ado, I'd like to introduce our first speaker. Volker Haase is Chair of Nephrology at Vanderbilt University and is Professor of Medicine at Vanderbilt. He has a research interest in oxygen and mitochondrial metabolism, and he's going to talk to us about the pros and cons of HIF-prolyl hydroxylase inhibitors. So Volker, if you'd like to share your slides, and we're ready to go.
Volker Haase is my name. I'm a professor of medicine at Vanderbilt University School of Medicine here in Nashville, in Tennessee, in the US. I'm a physician scientist, and I am a practicing nephrologist as well. And so I'm going to talk to you about some of the pros and cons of these novel anemia drugs, the HIF-PHIs, the hypoxia-inducible factor prolyl hydroxylase inhibitors. And I think, before I dive into the clinical data, just a couple of words about the mechanism of action. I think this is very important to understand the mechanism of action of these drugs. Especially since we have a relatively narrow therapeutic window. And what you need to understand is that these drugs inhibit enzymes that target the hypoxia-inducible factor for degradation. So hypoxia-inducible factor HIF is a key mediator of the cells and tissues hypoxia response, and it is a transcription factor that regulates many processes, many biological processes. A lot of genes are regulated, and I think 20 years ago when we talked about this as a potential therapy, there was a lot of concern by targeting a pleiotropic transcription factor like HIF. Because the concern was that it would do or turn on too many things. It happens to be that the erythropoietic response is very sensitive, so we just need a little bit of HIF to activate that. But when you go up with the doses of these HIF-PHIs, which inhibit these PHDs, you will, with increasing dose, also activate other transcriptional processes and other genes. So I think this is important to realize when we talk about dosing, and we'll come back to this point in a moment. So again, these drugs inhibit the prolyl hydroxylases that target HIF for degradation. And so when you inhibit the prolyl hydroxylases, activation of HIF follows, and you have increased transcription of genes, such as EPO and other genes that are relevant. And this just sort of illustrates the pleiotropic nature of this transcription factor. So many different pathways are regulated. Erythropoiesis, iron metabolism are very sensitive to just a little bit of HIF activation, and that's why this therapy actually works the way it works right now. There are several inhibitors that have been approved for marketing of anemia of CKD, 6 compounds. And we'll go into this in a moment. But just to alert you, there are also other clinical applications that are in development in terms of using other compounds or some of these compounds for other indications. As you know, there are trials, phase 2 and phase 3 trials going on with regard to myelodysplastic syndrome and anemia associated with chemotherapy. And these are other potential clinical implications: inflammatory bowel disease, sarcopenia of aging. There are clinical trials going on in those areas, and even lung injury, SARS-CoV-2. There are phase 2 clinical trials with regard to that. So the benefits of inhibiting HIFs, so the HIF-PHIs, so I apologize for the mistake in the title here. So the benefits of inhibiting HIFs and the use of using HIF-PHIs is as follows. I mean, first of all, these are oral drugs. So this has in different regions of the world different implications. So there's some logistical issues, for example, in the United States. So this could be helpful for patients on home hemodialysis, could mitigate the need for the need for going to a transfusion center to receive intravenous injections of EPO, for example, and it could be helpful in countries where refrigeration is a problem and things like that. The plasma erythropoietin levels that are generated by the HIF-PHIs at a efficacious dosing level are much lower than the EPO levels, plasma EPO levels that we generate by injecting recombinant erythropoietin. There are some effects from the preclinical studies and from the clinical studies that show effects on iron metabolism, and we will discuss the potential reduction in IV iron needs in the patients with CKD anemia. There's also some potential benefits, and I say potential benefits because we don't have the hard evidence from randomized controlled trials yet, but there's some potential benefits in ESA-resistant, EPO-resistant, hyperresponder, ESA-resistant patients, potentially some anti-inflammatory effects that also may play a role in this setting. And then some theoretical benefits, effects on blood pressure, potential protection from ischemic events, and effects on renal disease progression, beneficial effects potentially that have been suggested in preclinical studies that hasn't been shown really in the clinical trials yet, but maybe then we need more time to see those effects. These are the compounds that have been approved for marketing across the world. 5 compounds have been approved for marketing in Japan. So the Protostat, the GSK compound, and our Dustat, the Japan tobacco compound, Molidustat, Bayer compound. Roxadustat is a Fibergen compound that is being marketed in collaboration with Astellas in Europe and AstraZeneca. And Vadadustat, this is the Akebia compound. Vadadustat and Roxadustat have been approved in Europe. In the US, the Protostat right now only for dialysis. In Europe, Roxadustat for non-dialysis and dialysis, and Vadadustat for dialysis alone only. These are all oral compounds. These are the dosing schedules roughly. So what I've done here with the dosing ranges, I've looked at the dosing ranges from the phase 2 and phase 3 trials. We can talk about the doses in a moment a little bit more in detail, but this sort of gives you an example of the different doses that have been used, either once a day or 3 times a week, different half-lives, and these are plasma EPO levels that have been generated or reported with efficacious dosing. So in general, they are lower than what we generate with recombinant erythropoietin. They all inhibit all 3 PHDs, and they all activate HIF-1 and HIF-2. This sort of illustrated here, much lower plasma EPO levels that are generated with Roxadustat here in this case compared to recombinant EPO. So what about iron metabolism and efficacy? So let's start with efficacy before we get into iron metabolism. I'm just showing some example of the clinical trials. There's no bias in any way. I mean, I will show some data from different compounds. The drugs, all of the drugs do what they're supposed to do. They activate the HIF transcription factor. They stimulate the endogenous production of erythropoietin, and they stimulate erythropoiesis. And this is shown here. They are very efficacious, effective in a dose-dependent manner. And this is shown here. This is a trial in non-dialysis dependent CKD patients, the Olympus trial with roxadustat compared to placebo. And the drugs work as they're supposed to do. I put another trial here, Dolomites, in a non-dialysis dependent European study, non-dialysis dependent CKD patients. I put here an arrow in this graph. As you can see, the roxadustat response over time is shown here in red and darbepoetin in blue. The arrow is there because the FDA had concerns about this rapid increase in the hemoglobin levels in a very short period of time, and basically overshooting the target, the US target. And that was one of the concerns that led to a negative response with regard to marketing or approval in the United States. As I said, roxadustat is approved in many other countries, in the EU and in Japan and in China, where it was first approved in 2019 for both dialysis and non-dialysis patients. Yeah, so again, this is another example. So there was, FDA had a concern here in the US about this rapid increase in the hemoglobin levels. This is a dialysis, this is a study, the Pyrenees studies in dialysis-dependent CKD patients. So the drugs work, they do what they're supposed to do, they raise hemoglobin. They also have an effect on iron metabolism, and there are much more preclinical data available that establish how this exactly works, potentially works. In patients, what we see consistently is that there is an increase in transferrin production. There's an increase in total iron binding capacity. So transferrin is a classic HIF-regulated gene. And we can see this here in a phase 2 study with vadadustat, that you see a significant increase in total iron binding capacity because transferrin is upregulated. The drugs have also been shown to down-regulate or decrease the plasma hepcidin levels. As you know, hepcidin is a mediator of anemia of chronic disease or functional iron deficiency. High hepcidin level is not something that we're looking for, because that would sort of block the release and the utilization of iron released from stores and also iron uptake. So we are interested in creating a situation with lower hepcidin levels. And as you know, patients with CKD, they don't clear hepcidin very well, and they have some level of inflammation, and that increases hepcidin. So we have this situation, the higher where we have a functional iron deficiency, we're creating a functional iron deficiency basically by having a situation where we have high hepcidin levels in these patients. These effects are indirect. The effects that you see with regard to hepcidin are indirect. Hepcidin is not a HIF-regulated gene. It's anytime you stimulate the bone marrow to produce erythrocytes, erythropoietin is released, and that suppresses hepcidin production in the liver. The drugs have significant effects on iron metabolism, as we can see here. This is vadadustat. This is a recent study by Khoury et al. The first study that looked at iron, at red cell parameters, and what you can see when you look at in different patient populations, when you look at corpuscular volume, at mean corpuscular hemoglobin concentrations, at red cell distribution width, there is a beneficial effect on these parameters, so indicating that the red cells actually do better in terms of incorporating iron compared to ESA, which is darbepoetin alpha here in this case, which is shown in red. So you can see this here, for example, in this column, clearly very significant changes in mean corpuscular hemoglobin. So that's the first study that looked at RBC indices. The iron was not a primary endpoint, and there's a lot of data missing really to come to a firm conclusion. and no dedicated studies that specifically looked at iron utilization and need for iron replacement in patients with dialysis dependent CKD. But there's some data that suggests that there may be an iron sparing effect, an effect that lowers the need for IV iron supplementation. And this is essentially shown, illustrated here in this Himalayas study, incident dependent dialysis dependent CKD, 22% with absolute iron deficiency. Oral iron was allowed. IV iron was given at the PI's discretion for patients that had lower T-sats. There seems to be some iron sparing effect here, as illustrated here by the total or average dose of IV iron that was needed for roxadustat treated patients versus erythropoietin alpha treated patients. This was shown for roxadustat. Other drugs did not show this as strikingly as in this Himalayas trial. So these drugs stimulate erythropoiesis, and we have still a lot of questions how that will really impact the IV iron needs in the patients. And I think we can discuss this with the group then when we talk about the therapeutic window and dosing effects. You know, I don't have a lot of time, a couple of more minutes, but I'm just going to focus mostly on the global studies when it comes to safety. There are a lot of trials. Thousands of patients have been studied in these phase 3 trials. And this sort of gives you an overview of the global phase 3 trials with the 3 major drugs that have performed these trials: the protostat, roxadustat, ladadustat. They're very difficult to compare directly side by side to each other because comparators are different and also hemoglobin targets are different. In terms of non-inferiority margins, there were differences in terms of non-inferiority margins. Very difficult to do a side-by-side comparison. Several safety concerns have been raised, and I'm just summarizing this here before I show some of the slides, some of the data. So, and particularly in the non-dialysis dependent CKD population, there was an increased risk was detected when the drugs that when compared to ESA. There was this concern about thromboembolic complications. It varies a little bit also in terms of dosing. It's very difficult to compare these drugs side by side, but there is concern about thromboembolic complications, pulmonary hypertension, and it is difficult to distinguish the hemoglobin dependent effects, so rise over time and rapid speed over in rise over time, how rapid it rises versus the class dependent effects or compound dependent effects even. I think the long-term oncologic risk also remains unclear. The studies are still, although these were long, studies, I think that is not clear yet really what the long-term oncologic risks are. This is a theoretical risk that comes from the preclinical literature mostly. Some prolyl androgenic effects, the impact of these drugs on retinal diseases. VEGF is a target of HIF, and drugs in dose-dependent manner now outside the therapeutic window stimulate the production of endogenous VEGF. CKD progression, no signal really in the trials, but that's something that would have to be still addressed. And then there are other potentially compound-specific effects concerning infections, GI tract-associated symptoms such as esophageal and gastric erosions, and hypothyroidism for roxadustat. And I'm just going to say a few words of about the. I'm not sure whether you see that. I'm getting a little message here about something. the MACE analysis results, just showing you some slides for roxadustat, mostly in the non-dialysis dependent population. So did not meet non-inferiority criteria. That was the reason why this was rejected in the US. Vadadustat also similar concerns as shown here, and very regional dependence. So there's a regional dependency in terms of vadadustat in these trials. Non-US populations, more hazardous risk than compared to the US. And with regards to, the protostat had similar issues that resulted in a non-approval for non-dialysis in the US. And it really depends on how you do the analysis. When you do the on-treat, this is what the concern was. This is on-treatment, an on-treatment analysis, and the hazard ratio that was detected here with this particular way of analyzing the data was 1.40, and that's what essentially was one of the concerns that did not result in approval for non-dialysis, but the protocol was approved for dialysis in the US. I'm just going to skip these slides. We talked already about the adverse events, and I think you will have access to the slides, I think anyway, so you can look this up. But with roxadustat, thrombosis, sepsis, urosepsis, septic bacterial infection, and also seizure in the non-dialysis population was a concern. The relative risk is shown here. Again, in the dialysis-dependent population, thrombosis. And just a few words about the hyper-responders, running a little bit over time, but no randomized controlled studies exist really in that regard. And this sort of this idea or this notion that there may be a potential benefits in patients with ESA hyperresponse comes from these studies here in with roxadustat, where the patients were basically divided into two groups. CRP was measured, patients, two groups, patients with below upper normal level CRP, above upper normal level CRP, and then these investigators looked at the need for dose increases. So compared roxadustat to achieve target, compared roxadustat to ESA, and what is shown here is that the dose increases, there have more dose increases were needed to achieve target for ESA versus compared to roxadustat. So there's a lot of hand waving in this regard, and you know, I'm going to skip that slide. There are some more, not randomized controlled studies, but observational studies that illustrate that there may be benefit for roxadustat or HIF-PHI. In this case, a study from China, where patients were 30 patients, hyper-responsive patients, unclear how this was defined in this particular paper, were given roxadustat, and about half of these patients responded to roxadustat and reached the target level, which was 10 to 12 grams per deciliter, or 100 to 120 grams per liter. These are some of the parameters that were measured. As you can see here, there was an increase in TIBC as expected. Erythropoietin levels were not so dramatically increased. The investigators stayed within the recommended dosing range. So in this case, roxadustat recommended maximum dose was 2.5 milligrams per kilogram. So some potential benefit in patients with hyperresponse. This all needs further studying, and I'm going to stop here because I'm 5 minutes over time. I apologize. Thank you.
Volker, don't apologize. That was a lovely run through of the data. You made that very clear. I think we can see the controversies in this area, which you highlighted really nicely. So we'll save the questions for the third part of the session, although we do have questions coming in already, and we'll hand over to Lucia for the second talk. Lucia, if you'd like to share your slides, that would be great. Lucia is a nephrologist at the Azienda Socio-Sanitaria Territoriale in Como in Italy. She has a long-standing interest in the anemia of renal disorders, and she's going to talk to us a little bit more about novel anemia treatments. Lucia, thank you very much. Over to you.
It's my pleasure to be today to this webinar. And apart from my scientific interest, I'm a clinical nephrologist, and I work every day together with patients. So my presentation will focus on anemia treatment in real cases. HIF-PHI inhibitors are new agents for the treatment of anemia in CKD. They are now available for clinical use in many countries worldwide. As new agents, they represent an opportunity for our patients. However, we have to learn how and when to use them. The tradition and the novelty. Well, either are the tradition, HIF-PHI inhibitors are the novelty. From one side, we have 30 years of clinical experience. From the other side, we have new agents just released on the market. Both agents are in general effective to correct hemoglobin levels and maintain them in the relatively long term. Both reduce the need for blood transfusions, since they are anti-anemic drugs, but they have a different mechanism of action. One stimulate the APO receptor. The other stimulate the synthesis of endogenous erythropoietin. They differ from the administration route, since ESA, as you well know, requires a parenteral administration, while HIF-PHI inhibitors are oral agents. Both agents share safety aspects, and possibly HIF-PHI inhibitors have additive effect in increasing iron availability. Possibly they are more effective in inflamed patients. They reduce serum cholesterol, whether this could be considered a clinical advantage. And so let's start to merge the available evidence with everyday clinical practice. From what do we have? I live in Italy, so I will talk about my experience in my country. At the moment, the only agent available for clinical use is roxadustat. It is approved for dialysis and non-dialysis patients. Daprodustat and vadadustat have received EMA authorization for clinical use, but at the moment they are not available in Italy. Today I want to present you two clinical cases from two different perspectives. The first comes from the experience of clinical trials. The second case comes from everyday clinical practice. They started from randomized clinical trials. This man, Gianni, of course it's a fantasy name, he is 82 years old. He lives in Pavia, a region, a city close to Milan, and this is his medical history. And I thank Professor Esposito for the courtesy of giving me the case. When the patient was 60 years old, he developed atrial fibrillation. In the same period, he received a diagnosis of arterial hypertension. After 6 years, he had acute transitory acute ischemic attack. And at 74 years old, he started having his first heart problem. He developed atrioventricular block, and he was installed a pacemaker. After 5 years more, he developed dilated cardiomyopathy. At 81 years old, his lab exam showed chronic kidney disease with a serum creatinine of 2.4 and an estimated GFR of 24, that is CKD stage 4. For this reason, he was referred to a nephrological consultation, and at that time, he had also anemia with an hemoglobin level of 8.8, a transferrin saturation of 70%, and ferritin of 180. So it iron deposits were, let's say, borderline. Given the availability in that center of clinical trials, of randomized clinical trials with roxadustat in comparison to placebo, and the patient fulfilled the enrollment criteria, the patient will enter the study. And we guess, it was a double-blind study, that the patient received the active treatment, which was roxadustat, at the starting dose of 70 milligrams 3 times a week, because during follow-up, this was the hemoglobin target, during follow-up, after the start of the trial, he experienced a progressive increase in hemoglobin level till 11.7. At this point, the drug was stopped because of the end of the study. After a couple of months, he developed again anemia, as it was expected. So his physician decided to start him to a short-acting erythropoietin. However, during follow-up, hemoglobin level remained quite low, despite progressive increase in the dose needed, indicating hyper-response with new anemia treatment. And this is a second case that comes from clinical practice. This is an opposite perspective. In my clinical practice, to whom I would prescribe HIF-PHI inhibitors? Well, there are several possibilities. The fittest, the sickest, according to drug compliance, according to patient preferences, or possibly looking for an additional effect. And with this clinical case, I want to present you a possible reasoning in everyday clinical practice, arriving to whether or not prescribe this new drug as a new opportunity for that given patient. The clinical case is Mrs. Ivana. She is 75 years old, and unfortunately for her, she has many comorbidities, and luckily for her, she is passionate for music. She is obese. She has type 2 diabetes with complication, retinopathies and neuropathy, and diabetic foot. She has dilated cardiomyopathy with reduced ejection fraction, atrial fibrillation on anticoagulation therapy, and intraventricular device stimulator. She has CKD stage 4. She has liver steatosis, recurrent infection of the urinary tract, and then this is the last point of the long list. She also has obstructive sleep apnea syndrome. In August 2022, she made lab exams showing mild anemia with hemoglobin level of 11, serum ferritin 327, transferrin saturation of 15%, high folic acid levels, and she was on therapy with folic acid, in my opinion, for unknown reasons. Between September and October 2022, she underwent her first hospitalization. Her diagnosis at discharge was acute heart failure in dilated hypokinetic cardiomyopathy, infection of the urinary tract due to Klebsiella pneumonia. At admittance, she had high CRP levels, negative blood culture, positive urine for Klebsiella, high proBNP levels as we expect in acute heart failure with the need of oxygen therapy, a worsening of his anemia with an hemoglobin level of 10, and a worsening of his kidney function with a serum creatinine of 3.25. After a few days, her hemoglobin level dropped down to 9 grams per deciliter. Her anemia workup at admission was normocytic normochromic anemia, a high RDV, reduced platelet levels, serum ferritin of 284 with a transferrin saturation of 30%, normal ADH levels, high proBNP level, and high CRP level, and since the patient has an infection. This patient has several possible causes of anemia. Well, the first one, of course, obvious, chronic kidney disease, functional iron deficiency, inflammation, but also she could have a blood loss during anticoagulant therapy because of her atrial fibrillation, hemodilution, remember that she had acute heart failure, folate or B12 deficiency, unlikely, and finally, hemolytic anemia because of reduced platelet count. The colleague of the internal medicine unit started the patient at the admittance with epoetin alpha 4,000 units every week, together with oral iron. After a week, our kidney function improved, and also our hemoglobin level rose to 10.5, probably more because of erythropoietin, but probably more because she received diuretic therapy, and her CRP level improved because of antibiotic therapy. After 1 week, she underwent a nephrological evaluation that confirmed either treatment and oral iron and established a questionable hemoglobin target of 10.5 to 12. At discharge, the patient had an hemoglobin level of 11, serum creatinine similar to that of the previous year, and mildly elevated levels of CRP. And this is the long list of drugs that was prescribed to the patient at discharge. If we focus on anemia, we can see epoetin alpha 3,000 units twice a week, iron sulfate 80 milligrams a day, folic acid was maintained, and the patient was also prescribed empagliflozin 10 milligrams because of her heart failure. And I want to remind you that these agents also have an effect, a positive effect on anemia. Well, this patient has, apart from CKD, has clearly a chronic inflammatory state. And this has a therapeutic implication on iron therapy. Iron dysregulation during inflammation is multifactorial. We have reduced iron absorption in the bowel. We have iron retention in macrophages and of the reticuloendothelial system, but also we have a reduction in circulating half-life erythrocyte, inadequate production and activity of erythropoietin, and impaired proliferation differentiation of erythroid progenitor cells. Said that, it is unlikely that oral iron could be effective in Mrs. Ivana. And so the first question is, would I prescribe intravenous iron to this patient? Well, there is possible advantages. Our intravenous iron is certainly recommended by guidelines for patients with heart failure and functional iron deficiency. However, this is a very frail patient with several comorbidities, with an high infection risk, with antibiotic resistance. And I remember she had CRP levels below the normal level of normality at discharge. After 1 month, the patient came back for an outpatient visit. At that time, the patient had mild fever. Her body weight had increased of more than 10 kilos because of water retention. And lab exams showed a marked increase in serum creatinine and CRP level, and sign of infection of the urinary tract with yeast, and again, positive culture for Klebsiella. The patient was entered again to the hospital and remained there for 3 months. Her diagnosis of discharge was acute kidney insufficiency, stage 3, inceptive shock, secondary candida, acute heart failure needing CVVH, infection in urinary tract due to Klebsiella, Escherichia coli, enterococcus infections, and finally the patient also got an enteritis from Clostridium difficile. At that meeting, the patient had the worsening or anemia 8.7 that dropped more down to 7.8. The patient received several blood transfusions during her stay in the hospital. At discharge, her hemoglobin level was 9 grams deciliter, and her serum creatinine went back to her usual levels. At discharge, her therapy for anemia was again folic acid, epoetin alpha 4,000 units for 3 times a week, again oral iron, and luckily empagliflozin was finally stopped. And so let's go back to the initial question. Would I prescribe a HIF-PHI inhibitor to this patient? Maybe. Here I want to show you this table of potential advantages and disadvantages. That is the result of the opinion of expert at the controversies conference on this drug that was held in December 21 by KDIGO. Well, HIF-PHI inhibitors, among potential advantages, we have oral dosing, more convenient for some patients. They may facilitate anemia treatment in patients with non-dialysis KD patients, as it is the case of Mrs. Ivana. They may improve iron utilization, particularly for oral iron. They may be effective during patients with chronic inflammation. And let's move to the potential disadvantages. On the contrary, it's difficult to monitor adherence. They possibly imply potential polypharmacy and drug-drug interaction. We have less clinical experience since they have just arrived on the market. There is a potential risk of worsening retinopathy, in this case with diabetic. And well, what else? Well, is it possible that HIF-PHI inhibitors improve heart function? Well, theoretically, yes. Cardiomyocytes in diabetic patients are less tolerant to hypoxia, and indeed, a diabetic patient developing acute myocardial infarction usually have a higher infarctual area compared to non-diabetic patient. In diabetic patient, if one alpha stabilization is blunted and downstream activation of adaptive hypoxic response is reduced in the patient on insulin resistance. This reduction of HIF activity is mediated by increased fatty acid inside the myocardium. In this regard, in 2021, an interesting experimental study has been published using an in vitro model of human cardiomyocyte exposed to insulin resistance and hypoxia. As you can see in normoxia controls, this is, let's say, the basal level of PH2 mRNA activation. Following the exposure to hypoxia, as expected, PH2 mRNA markedly increased. However, following the exposure to insulin resistance, this increase is reduced. More than that, hypoxia reduced nearly to zero the response to hypoxia. This is restored with the treatment with monidostat. And then, would I prescribe the HIF-PHI inhibitor to this patient? Well, let's start from the pro. Possibly more effective in inflamed patient, as it is Mrs. Vanna. They could possibly increase the iron availability and thus avoid the need of intravenous iron, and possible effects on heart function, very, very theoretical. And the contra, well, the patient is already taking a long list of pills. It is unknown whether increased iron availability has the same effect as intravenous iron on the heart. Possibly effect on the heart function, yes, but at the moment, the data from available clinical trials from phase 3 clinical development did not show at secondary analysis any significant positive effect in this respect. However, to your knowledge, there is a trial that has been designed testing this hypothesis. Our patient, it's true that she has inflammation, but has no sign of his hyperresponse. And there is no, as I already said, no clinical evidence on our protection. And there is a remote risk that prescribing this drug, we could have a worsening of diabetic retinopathy due to an increase in vascular endothelial growth factor. However, for knowledge, available evidence till now in studies that have been monitoring high exams, there is no evidence of worsening of diabetic retinopathy with the use of these drugs. And then I move to the final slide. And thank you for the attention. And well, I will still have to decide whether to prescribe the HIF-PHI inhibitors to Mrs. Ivana. And for sure, when I will prescribe it, I will show you the effect or possibly the non-effect of this new treatment in my patient. Thank you for the attention.
Thank you very much, Lucia. Very nice presentation. I think just illustrating the complexity of the patients that we manage and the number of comorbidities that these patients have and the difficulties in planning treatment because of all these comorbidities. So thank you very much for that. So we're now going to move into our question and answer session. So thank you both for joining us again. And we've got plenty of questions. I'm going to start with this one about low to middle income countries, remembering that we have an international audience today. What are the advantages or potential advantages of HIF-PHIs in low to middle income countries? Volker, let me ask you that one first.
Yeah, obviously an advantage would be, in my opinion, I don't know what the pricing structures are in the developing countries and how difficult it is to refrigerate, EPO, and all of these things. But I mean, the oral availability, I mean, an oral drug would be a clear advantage with all the downsides that come with it, right? In terms of monitoring and making sure that the patients understand, you know, it's not just one tablet, it's tablets in different things with different, like a 10, 50 milligrams, 70 milligram, 20, 10 milligram tablet that they're you know, raises concerns about compliance. So, I mean, understanding all these risks, but I mean, I think the advantage would be, you know, it's an oral drug that somebody can take remotely and with proper monitoring. I mean, I think it would be a big advantage. Cost-wise, I don't know. I mean, it depends on, that's something, you know, I'm not part of the cost negotiations, but this
is going to depend on the companies, isn't it? But the potential actually to reach patients who are difficult to reach with ESAs because of the need for injection and the need for cold storage with ESAs. So potentially a big advantage in hot countries. Lucia, I'll ask you this one. This is about CKD5 patients, so patients on dialysis, patients who are transplanted. In comparison with ESAs, how safe? And I know, Volker, you showed some of this data, but let's just get Lucia's view first and then perhaps come back to Volker. So as safe, safer, less safe in CKD stage 5D dialysis and then separately kidney transplant recipients.
Thank you for this question. Well, data from, let's say, dialysis are regarding safety are possibly more reassuring comparing non-dialysis patient. And as a matter of fact, all the molecules have received dialysis approval, not entering the tail FDA or EMA, while two molecules were not approved in non-dialysis patients. So for sure, there are less safety problem. It should be noted that the European Medical Agency approved roxadustat at the condition of not shifting the patient from ESA to roxadustat in the absence of a clear clinical reason, and this should be kept in mind. And so, going to transplanted patient, in general, they have been excluded from clinical trial. So the data that Dr. Haase has presented today do not take into account patient with kidney transplantation. So there is a very, very limited experience, just some case report in the literature. And I think that great caution is needed in this class of patients for several reasons. First, if the inhibitors could have important interaction with other agents. And at the moment, we do not have clear information of possible interaction with agent for anti-rejection. And also considering that these drugs act on the inflammation and the immune system, we do not have data on whether could be the possible effect in increasing or reducing the risk for a rejection. So very, very big caution with this category of patients.
Thank you, Lucia. Volker, do you want to add anything? You showed some of the data from the comparisons of ESAs and HIF-PHIs in dialysis patients.
Yeah, yes, I did. I mean, it was, apologize again, there's not a lot of time to go through this in more detail, but I mean, I wanted to throw this out to have a platform for discussion.
Yeah.
I mean, obviously, a lot of patients were excluded. I mean, also, you know, I saw this in the chat coming up. I mean, cancer patients, should the HIF-PHIs be used in cancer patients? I mean, certainly with active cancer, I would say no. And if you look at the you know, clinical trials, that the exclusion criteria were like 2 to 5 years at least cancer-free before the drugs were, I mean, in patients with a history of cancer before the drugs, before these patients were eligible for trial. So, I mean, there's still a lot of theoretical, there's a theoretical risk. And as you know, in a different world, in the cancer world, we actually use an inhibitor of for the treatment of renal cell cancer, for example, right? I mean, these HIF-2 inhibitors that have been used. People are trying to target. So, you know, that just was an example of another group of patients. I mean, I think in terms of another patient, a question came up with patients with polycystic kidney disease. High-risk cysts, patients with high-risk cysts, based on the Bosniak classification, they were excluded from the trials. There is patients with polycystic kidney disease. I mean, are they at risk of cyst progression? Some preclinical studies suggest that. So I would be also careful with regard to patients with polycystic kidney disease. I mean, I think for when they're on dialysis, that's a different story. But there are also other patients, so several patient groups where you could, where we don't really know. I think there needs to be more granularity in terms of how, what is the right patient group? Is, you know, somebody with retinopathy, would I give a HIF-PHI? I would still shy away from that, personally.
So caution in patients with malignancy, particularly if that malignancy is in remission, but the same, I guess, with the ESAs. Caution in patients with adult polycystic kidney disease, because we didn't include them in the trials. Particular caution in any patient with renal, potentially malignant renal lesions. So that's helpful. A couple of questions on SGLT2 inhibitors, and it strikes me that we are talking about novel anemia therapies, and some people, I think, see the SGLT2 inhibitors as potential anemia therapies. So one question here is, how would empagliflozin help anemia? Who wants to take that? Volker, do you know the mechanisms, or Lucia?
Well, I can say that the mechanism is complex. However, I know that there is an interaction at the kidney level on the HIF system, given that these drugs can modify the energy expenditure of the kidney and also the oxygen content of the parenchyma. And more than that, it has been shown that this is a true effect that goes through a modification on the synthesis of erythropoietin. So it's not just due to hemoconcentration due to the mild diuretic effect of these drugs. Say that they cannot be considered true anti-anemic drugs, since, in my opinion, the effect on hemoglobin level is mild. So it's an ancillary effect, but it's not a reason to start these drugs just for improving anemia. I don't know, Wheeler, you're a much better expert.
No, I'm glad you said that. The SGLT2s are not anemia drugs, but they happen to increase hemoglobins in many of the patients that we've treated in the trials. Volker, anything to add?
Yeah, just one comment. I mean, I think you're absolutely right. It may actually, somebody who is on an SGLT2 inhibitor, I mean, in that patient, the start of the, classical either ESA or HIF-PHI may actually be delayed a little bit, because there may be some beneficial aspects initially, effects initially with regard to the development of anemia. That could be, I mean, I could envision, I mean, I could see that might happen. Then the question becomes, once they go on dialysis, and the different, I mean, obviously we have when do we normally give SGLT2 inhibitors, right? I mean, do we give this to patients on dialysis? No, I mean, this is a whole.
Yeah.
But I think in those patients that are early on, let's say CKD3, advanced CKD3, CKD4, I mean, I could potentially see that if they're on both drugs,
yeah,
that may impact the dosing that is needed for anemia treatment.
We've only got 4 minutes left, so just some really quick questions. Possibility of prescribing these drugs in patients with no kidneys at all. So bilateral nephrectomy, do these drugs still work? Either of you?
Yeah. Well,
yep.
According to data going back at phase 2 studies, this drug has been given to also to an nephric patient, and they are effective anyway, because erythropoietin is not synthesized only by the kidney, but also by the liver. So if the inhibitors, depending on which molecule, have also an effect on the synthesis of erythropoietin by the liver. So the answer is yes, they're effective also in nephric patients.
And a question about whether the trials included people from Africa, Asia, or just Caucasians.
I think, there are a lot of trials that have been done across the globe. Most of the phase 3 were global studies, which included patients from South Africa or South America and Asia, obviously the Japanese, China, right? I mean, I think, we want to go into the details, you have to look in the individual studies. But yes, I mean, there's a whole, it was, in terms of the design of the studies, attention was paid to ethnicity and representing these different ethnic groups.
And then this will have to be the last question, but the role of these drugs in treating anemia in other chronic diseases such as rheumatoid arthritis, SLE, Volker, I think you just touched on this in your talk. Will they work?
Yeah, I mean, there are trials going on in low-grade myelodysplastic syndrome, MDS with roxadustat. There are trials going on in anemia with chemotherapy. There are different, I mean, that's a possibility. Nothing has been really studied with regard to rheumatoid arthritis or lupus, but I mean, the drugs, stimulate erythropoietin, so that may have some, would have to be studied, right? But there's a possibility, yes.
Good. Well, there's more questions, but we need to stop there to keep to time. A huge thank you to Volker and to Lucia for their talks today. Very clear talks, I think, have very nicely contextualized these new drugs, helped us to understand not only the potential benefits, but also the potential hazards of therapy, and also helped us understand which patients perhaps we might be using these drugs in. So thank you very much to both of you. Thank you to the International Society of Nephrology and to KDIGO for supporting this webinar. And thank you to all of you who participated. I think we peaked at about 263 participants. So thank you very much for joining us today. We hope you found that of value. I know that there's a feedback process that allows you to comment on the webinar, and that always helps us obviously develop webinars for the future. So thank you to everybody. Enjoy the rest of your day or night, wherever you are in your day. Thank you for joining us, and hope to see you on another ISN webinar in the future. Thanks everybody, and goodbye.